It is my pleasure to award the PHC award to Nora Thérault. Nora is a truly remarkable woman. By her depth of intellect, passion, and kindness, I take great pride in telling you about her personal history and accomplishments. She was born at Edmonton in Canada, in a family with 8 children. She made her medical studies at the University of Alberta. She made her internship, residency, and fellowship in gastroenterology at the University of Toronto. There, she met Jenny Ivcoat, and Jenny introduced her to Bruce Scharschmidt, and off she went to the University of San Francisco, UCSF, as a research fellow, training with Terry Wright. It was during this time that she also obtained a master's in public health at the University of California, Berkeley. Armed with these exceptional credentials, she was invited onto faculty at UCSF in 1997, where she worked with John Roberts, a liver transplant surgeon, and Marion Peters. She stayed at UCSF until 2019, serving as the director of the Viral Hepatitis Center and the Transplant Hepatology Fellowship Program. And in 2019, she assumed the position as the chief of the Division of Gastroenterology and Hepatology at the University of Southern California. His scientific contributions, she published more than 400 papers, and she was a PI of national guidelines for treatment of HBV and HCV and reproductive health. She worked mainly on viral hepatitis and NAFLD, with a special focus on cirrhosis and transplantation. She was a PI of multiple clinical trials, and especially NIH-funded studies, the NIH network, HBRN, the Non-Alcoholic Steatohepatitis Clinical Research Network, and the Liver Cirrhosis Network. She was a successful mentor, and 90% of her mentees had an academic position, and she indeed is well known for her educational skills, and she was beloved by her patients and her mentees. And among her many contributions, she studied the role of ethnicity, race, and sex in the prevalence of chronic liver disease and in the natural history and risk of cirrhosis and liver cancer. Nora's group was also the first to highlight differences in HCV outcomes after liver transplants by recipient sex and donor race. She has contributed to highlight the important differences in liver-related complications between men and women. Nora helped to develop predictor score and models to detect and manage transplant patients. And she studied especially the patient with alcohol-induced liver disease. She is acknowledged as a leading investigator, and she is also an outstanding editor and writer. From the clinic to the classroom, I would say Nora is respected as a clinician, and she is very, she takes care very nicely of her patients. Everybody knows she has, her patient trusts her completely. And And for teaching, Nora has continued to teach since 1999, and she she is the recipient of many awards, and among the awards we can distinguish a prestigious gold medal award from the Canadian Association for the Study of Liver. Nora really loved to teach, and during her career, she taught the staff, the students, and many mentees who were accompanied by Nora and had made a good career, academic career. The value of Nora's mentorship is well represented by the fact that most of them stayed in clinical research or clinical care. And another feature of Nora's success as a mentor is her ability to make her mentees feel seen and heard. She'll always make time for her mentees. We would be remiss if we do not acknowledge a role in inspiring women in hepatology to become leaders in medicine. And very importantly, recently, she was nominated as the president of ASLD, and she is the 6th woman to be president of ASLD. This is a ceremony when she received this honor to become the president of the American Association. What about her personal interests? She likes to travel, and we know that there is no place on earth she won't visit. She likes hiking and cycling, and people say that she's taking a bicycle to go to the hospital and university. She likes dancing. Anyone who has seen Nora at liver events can attest to this. And also she has been trained in classical piano, and she's also a musician. So I think what is characterizing very well Nora is what she's saying usually to her mentees, her colleagues: be kind and work hard. This is really the image we have of Nora. And Nora, I am proud to award you this PHC award as a testimony of our admiration and friendship. Thank you. Nora, are you here? I think Nora is probably in California. This is about 5 in the morning. Maybe we cannot connect with Nora. Anyway, Nora, thanks again. We will have now the presentation of Nora. Please, Nora, I give you the word, please.
Hello, it's terrific to be with you. And I want to thank Professor Marcelin for the very generous invitation to be part of the meeting and for the great honor in presenting the state of the art. I'll be addressing liver transplantation today and tomorrow. The global burden of cirrhosis remains high. It's ranked 10th globally as a cause of death, with 1.5 million deaths in 2019. There's great variability by country, as shown in the figure on the left, with the highest rates in parts of Africa and Asia. You also see on the right that in even countries where we have access to wide access to care and treatment, that US mortality related to cirrhosis is also increasing, as in other countries. Shown in the bars are rates of death from chronic liver disease, cirrhosis, and hepatocellular carcinoma between 1999 and 2017. And striking among the trends is an increase in cirrhosis deaths among those that are young, under the age of 40, and a rise among women. In addition to seeing this rise in rates of cirrhosis and its mortality, we're seeing shifts in those that ultimately present for liver transplantation. So liver transplantation is the rescue therapy for those with complications. And we've seen a shift with less HCV, more NAFLD, and more alcohol, including alcohol-associated hepatitis. And HCC as an indication for liver transplantation remains prominent in many countries, an important opportunity to provide a curative therapy for individuals with small HCC. So the trends are shown on the right. You can see US on the top, Europe on the bottom. But in both cases, a very dramatic decline in HCV with the advent of DAAs in about 2014, and with NASH and alcohol now becoming sort of number one and number two in many countries. Now, regarding alcohol-associated liver disease, there's been a marked shift in recent years. We have moved away from a requirement for 6-month sobriety as a requirement for liver transplantation. And in part, this was fueled by rising rates of severe alcohol-associated hepatitis, where having 6 months of sobriety is just not possible because many will die within that 6-month period. And so we've shifted towards using a more comprehensive psychosocial evaluation that is looking at ways that we can better predict relapse to alcohol use after transplant. Shown on the right is really the marked increase in transplantation for alcohol-associated hepatitis. This is US data with a striking increase that occurred with the pandemic, and it's still continuing. In general, with alcohol-associated liver disease, there's increasing recognition of alcohol use disorder as a chronic disease, one that needs management both before the transplant, but as well as after the transplant. And just to highlight the very remarkable outcomes when you offer early transplantation for alcohol-associated hepatitis, we have 2 multicenter studies shown here. On the left, the Accelerate AH cohort from the US, and on the right, the French-Belgium cohort called Quick Trans, the study. And you can see when you compare transplantation without a mandated sobriety for ALC-HAP to those that have alcohol-associated cirrhosis, or those that had a standard 6-month sobriety, that there is no difference when we look at survival out to 2 and 3 years. So these are very encouraging results and have led to the acceptance of alcohol-associated hepatitis in select patients as an appropriate indication for liver transplantation. So in terms of the future for ALD and liver transplantation, I think we're going to continue to see this to be a dominant indication, but we need to focus continually on how we do better patient selection, eliminating bias in that process by bringing more objective tools to help us to predict high risk for relapse of alcohol use after transplant. And we need to become better at managing alcohol use disorder, and increasingly transplant centers are looking to embed alcohol use disorder treatment in their liver transplant care teams. And there's increasing interest in the use of medications to assist with managing alcohol use disorder. And then, we have to also recognize that patients who have alcohol-associated liver disease not only are at risk for liver-related complications with alcohol use after transplant, but also have higher rates of cancer and cardiovascular disease. So attention to reducing these non-liver-related mortality is also key. Now, moving on to NASH. This is the most rapidly rising indication for liver transplantation globally. I show you results here of trends in the US, Europe, India, and Japan, just to give a sense of the global nature of this rise. And we've come to, I think, recognize that with this becoming the most rapidly rising indication, that in the future, it's likely to be the dominant disease. And how frequently will we be dealing with recurrent disease? Well, this recent study suggests that it's probably inevitable, and certainly is frequent. This is a 19 liver transplant center study from France and Switzerland, recently published. They have 150 patients with at least 1 liver biopsy. Note that 86% of the patients had some element of metabolic syndrome, 5 years after transplant. So very frequent. And we see 60% have NASH and 20% have advanced fibrosis when we look 5 years post-transplant. So dealing with recurrent disease is going to be one of our major future challenges. And how are we going to deal with it? Well, I think we have to think both in terms of prevention as well as the treatment of recurrent disease in the transplant setting. For example, bariatric surgery is already being considered in liver transplant candidates and recipients. There's a recent data suggesting maybe statins have a benefit in improving survival and outcomes in patients with NASH. And clearly, immunosuppression modification is going to be very relevant because all of the immunosuppressive drugs we use have a tendency towards exacerbating metabolic comorbidities. So how we use immunosuppression could really influence metabolic syndrome and associated risks of recurrent NASH. And then finally, and you'll hear much about new therapies, I'm sure, at this conference, we need to look to see how those new therapies can be applied to our patients with liver transplantation. Now, moving on to HCC, and as I mentioned in the onset, it's been several decades now that we've known that patients who have HCC within Milan criteria have excellent 5-year patient survival in the 70 to 80% range. Over time, we've expanded the criteria modestly, and now there are many approaches to downstaging patients, so starting with tumor burden that is either of greater number of lesions or size, and then treating them with local regional therapy in order to get them to be within Milan criteria. And this has shown success and allowed a broader range of patients with HCC to be considered for liver transplantation. What we know with downstage patients, so those that start outside of Milan but are brought to within Milan, that there's higher rates of dropout on the list due to tumor progression. I do have slightly higher rates of recurrence of HCC post-transplant, but overall survival rates still in the 50 to 70% range. So well recognized as an important advance. And as we look towards transplantation in the realm of oncology, there's even newer areas where we're seeing transplantation applied. Shown on the left is liver limited colorectal cancer metastases, showing that there's a highly effective therapy in select patients with excellent overall survival as well as disease-associated survival. And then on the right is small intrahepatic cholangiocarcinoma, also showing that this is also in select patients, small lesions can be treated effectively with transplant with modest rates of recurrence. So we're starting to see this expansion. And as we do so, there are concerns being raised. And I think these are the ones that are going to have to be addressed if we're going to see an expansion of transplant oncology. They include dealing with the organ shortage, the recognition that while their survival using transplant is better than a non-transplant alternative, that overall rates of survival may be less than our non-cancer etiology. So we have to look at the equipoise and offering transplantation to an expanded number of patients with cancer as their indication. And then there's more to be learned about the potential negative consequences of immunosuppression on cancer recurrence post-transplant. Now, I mentioned that, there's a concern about as we expand indications, do we have enough donors? Already, we know that 1 out of every 5 patients that's on the waiting list will die without transplantation. And in part, this is related to our donor lack of donors. Shown here are US data highlighting that in a given year, 18% of patients on the list die or become too sick for transplantation. So there's a lot of interest in how we can expand the donor supply. And I show here where our current focus is on, we've expanded our deceased donors to include use of viremic donors. That's an area of expansion. Of course, living donor liver transplant remains an important option. And technical innovations, including robotic surgery, are really advancing, I think, that area. But what I wanted to highlight are sort of 2 areas. One is there's been some very exciting developments in xenotransplantation. Liver is a little bit behind heart and kidney, but we've seen publications in the last year that using genetically modified porcine allografts that we can actually have humans survive. So this is going to be something I think we'll see much more of in the future. What I also wanted to highlight is, I think, a very exciting area, and that is around machine perfusion. And we know that there are many organs that are available, but they're not of the high quality that we want to see to utilize. So a standard quality liver has to be under the age of 65 without steatosis and with a relatively short cold ischemia time. But if we could expand to more marginal donors, that would really help to overcome our donor shortage. And there are now very many new techniques to precondition these liver grafts in order to make them less susceptible to the injuries that are typically associated with marginal quality organs. And here's just one study to show this. They were using deceased cardiac donors, so donation after cardiac death donors, so DCDs. And what they were comparing this to was using a normothermic regional liver transplant approach versus just doing DCDs, but with a very rapid recovery and transplantation. And what they showed is using the normothermic perfusion methods that they saw significantly lower rates of biliary complications and of graft loss, highlighting the potential for machine perfusion to take donors like a DCD donor and make them donors that are going to be usable and with lower rates of complication. And then finally, we need to look towards how do we improve long-term patient graft survival. Overall, when we look at 5-year results, they're excellent. But when we look at 10, 20, and 30-year outcomes, actually there hasn't been much improvement in those very long-term survivals over the past decade or two. And when we look to why do patients die sort of beyond that 5-year mark, you can see that non-hepatic causes come into being much more important: malignancy, infection, and cardiovascular disease, accounting for 75% of long-term deaths. And we recognize that transplantation, while life-saving from the point of view of the liver, brings with it additional really metabolic and malignancy risks. And shown in this figure is the proportion with which those risks increase post-transplant. And I think this is going to be even more challenging for us in the future because our pre-transplant patients are going to have more NASH, they're going to be older, they're going to have more metabolic syndrome, more renal dysfunction. So we're going to see even more of these complications post-transplant. So again, this is where our future really needs to focus, is how do we prevent and treat these long-term immunosuppressive complications? And again, focusing on how do we minimize obesity, metabolic diseases post-transplant? How do we do better renal protection of those kidneys? How do we do better cancer surveillance and or interventions? And in particular, how do we think about doing better cardiovascular disease? These are the challenges we have for the future, and be really relevant so that we can see patients that are thriving with their grafts decades later. And then finally, the most desirable outcome, given that we recognize that immunosuppression brings with it those risks, would be to do immunosuppression withdrawal, so getting to tolerance. We now know through many studies that about 20 to 30% of liver transplantations can be weaned off immunosuppression completely and be tolerant. And we've got some ideas of what those best candidates are. But this slide is just to say there are really a lot of progress being made with how we think about doing immune manipulation that will hopefully allow us to even get to a better place in terms of being able to offer immunosuppression withdrawal to more patients in future. So to close, I want to highlight that looking to tomorrow, I've shown you transplant indications have changed. Our recipient phenotype has changed and is changing, so it requires us to be thinking differently about transplant. There are increasing donor options that I think are very, very exciting. And we need to, I think, look to really the long-term survival of our patients by improving our post-transplant care through management of the metabolic risks, alcohol use disorder, and optimizing immunosuppression. Thank you very much.
Thank you very much, Nora. Thank you for this remarkable state of the art on liver transplantation. Nora, I realize that you are the second lady to receive the PHC award, and the first lady was Jenny Ifcoat, and I know Jenny was really your mentor, very important in your career, and we think of Jenny with a lot of friendship. Nora, may I ask you a question? Since you are now the president of ASLD, and congratulations again for that. This is quite an honor, but you deserve it. What is your ambition for ASLD? What are your projects?
First of all, Patrick, I just want to thank you again for really this great honor. I am, and now that you tell me that I am the second and that Jenny was the first, this just actually makes it even more special to me. So really, I am deeply, deeply honored. Thank you so much for this award. I'm very, very humbled by it. In terms of the next year, I'm already partially into my year as AASLD president. I am very, very focused on viral hepatitis elimination. That's not new, but in the United States, we have recently kind of had a lot of initiatives around this because we have a national strategic plan that's coming forward. And I think it's very apropos to this conference. You'll hear a lot about viral hepatitis. There's exciting work that's occurring, but we all know that this is indeed hepatitis B and C are diseases we can eliminate. So I'm making that a major focus of the year that I'm president, and hoping that, of course, it'll continue much beyond that. I'm also very interested, of course, you highlighted that I've always had a great interest in mentoring and in particular supporting the careers of women. And so I'm very, I'm very focused on an initiative that'll work towards developing leadership opportunities on a more global basis for women in hepatology. That's a second initiative that I've made one of my key areas for 2023. And I think the last is just the continued working on partnerships, global partnerships. We are very grateful for partnerships that we've had, for example, with EASL and are looking towards strengthening partnerships across other societies, because we realize that the world is really becoming a place where we all have much more to learn from each other and much more that can be done if we work together. So I think a lot of very important initiatives are occurring across societies now, and I am very, very interested, very keen to ensure that that continues to advance. So those will be the key things that I'm working on this year. I'm sure there's more that'll evolve as the year takes on as I get through each month, but that's where I'm going right now. Thanks.
Thank you, Nora. I wish you all the best, and probably see you in Boston in November.
On the dance floor.
Oh, yes, yes. With pleasure. Take care, Nora. Okay,
Thank you.
We have a break, and please visit the booths, the virtual booths. And after the break, do not miss the Delta session chaired by Mario Rizetto and Tariq Assela. Thank you.